Okay, hi everyone and good afternoon. This is Mauro Brilakis, and together with Mehdi, Subhash, Banerjee, and Paul Sorajja, we're delighted to host today's webcast from the Cardiovascular Innovations Foundation. We are delighted to have four outstanding experts that are going to discuss about primary PCI versus thrombolytics for for patients with ST elevation myocardial infarction. We're going to start with Dr. Naidu from Westchester in New York, who actually is the senior author of the recent FSCAI document on the approach in the Cath lab to COVID patients. Then we're going to go across the Atlantic to Italy to Dr. Mauro Carlino, one of the CTO world experts, which is going to discuss the local situation and how they'll be dealing with a large number of patients. Then we'll switch gears and go to New Orleans with Dr. Patel, who's going to describe their experience and how they're handling this volume. And then finally, go to Chicago with Dr. Sandeep, who's going to discuss the local dynamics and his own experience with one of those patients with suspected COVID as well. So without any further ado, I would just like to kick it off. Welcome everyone. Thank you for being here today. I think this is a question that comes up to everyone's mind. And then we'll have Hari kick it off.
Okay, great. Thank you, Manos, and thank you to CV Innovations for the opportunity here. I think this is a very, very important topic, and certainly in our institution, we've had significant discussion about this. And what I'm going to do is take you through some of the discussions we had at FSCAI in the Emerging Leader Mentorship Program that formed the document that came out about a week ago. Obviously, the topic of primary PCI is very important, and with constraints to the system, we have to find a way to balance how we better take care of these patients during this epidemic, and also balance our resources and our staff. So what I'm going to do is take you through this document. So behind the scenes, about 2 weeks ago or so, we really tried rapidly to put together a consensus document to give guidance. It was very clear that a storm was coming, a storm was brewing, and it's very important for us to gather the minds of a variety of people around the country and the world and try to give some guidance to institutions that either have not seen this yet or it's impending. Certainly in New York here, we're seeing a lot of these patients, and there's been a huge burden on the system. And right now we're making do and getting by, and patients I think are doing pretty well. But I think as the system gets overwhelmed, we have to make some decisions. And I think I'm hoping to learn from our Italian colleagues and other colleagues in this space. So this document came out and was really rapidly published within a week. We wrote this over the course of 3 days and got it through SCAI and the executive committee and published it in CCI. As you can see, there's 25 authors from the Emerging Leader Mentorship Program from around the country. And the lead author was Molly Zerl, who did an outstanding job herding us together towards this final destination. So the areas discussed in the document include cath lab environment and staff preparedness for suspected and confirmed COVID patients, optimal donning and doffing of PPE, staffing algorithms to minimize exposure to staff and maximize team availability, procedures and subsets that can be safely deferred, such as low-risk non-STEMI patients, if suspected or confirmed COVID. And what I'll talk about more here and forms the framework for the rest of the hour or so is the handling of emergent procedures, including, of course, STEMI and high-risk non-STEMI, but also some of the procedures that we felt could be performed at the bedside in COVID patients, such as pericardiocentesis, balloon pump placement, TBP, and some forms of ECMO. And when we looked at this document and how we handle these patients, we initially thought that we would separate the patients into either people under investigation for COVID or COVID positive versus those who are not suspected of COVID or have or documented COVID negative. And some of the considerations in those subgroups, so for patients who are low risk for COVID or actually negative, these are the things that came up. What is the prevalence of asymptomatic COVID in the community? Are you sure, or how sure are you that they are non-COVID? COVID testing, as we know from swabs, detected about 70% of disease on the initial test, maybe a little bit more on a subsequent test, but it's not 100%. So does the patient actually have COVID and a subclinical pathology with secondary cardiac involvement? And there have been some cases of patients coming through the cath lab with a typical STEMI, and they're found to have COVID a couple days later, because as you know, there's an incubation period and a subclinical period. Is this simply a primary coronary event completely unrelated to COVID? And we don't want to miss those. It's very clear that if you miss some of these, you can increase mortality in a non-COVID population. Is your DOTA balloon time and system strained or running properly? A very important consideration. What is routine PPE for these patients, and what is the risk to benefit ratio bringing the patient to the lab, both in terms of the patient, which we've always talked about, but also now in terms of staff exposure and the risk therein. For patients who are under investigation and COVID positive, it becomes a little challenging as well. So is this a real ACS STEMI, or is it an epiphenomenon of COVID? So we know that there is an incidence of myocarditis in these patients, stress cardiomyopathy, vasospasm, or other etiologies. And it's important to discern the two. And is there any role for upfront testing, including X-ray, echoes, or CAT scans? And this is something I'd like to hear from the rest of the panel over the next half hour or so. What is the overall prognosis, and what is the relative value of primary PCI in this setting? Now that the mortality is higher in a subgroup, what do we know about the value of PCI in that setting? There are exposure implications, and whether these can be minimized by intubation, pre-procedure, cath lab preparation, and PPE. And can we achieve door-to-balloon times realistically of less than 90 minutes in this patient population where there's lots of other concerns and comorbidities as they come in? And finally, what are the risks and benefits to coronary angiography with PCI versus lytics? And we'll talk a little bit more about that in the subsequent slides. So this is a flow chart that my colleague, Dr. Levine, put together this morning as he presented us about myocarditis in one of our heart failure transplant physicians. I adapted it slightly just so you can see that we're trying to put in buckets what can happen when you have a low EF in a patient with COVID. So on the left side, you can see some of these patients have a primary pulmonary insult. Obviously, they have ARDS, but they can have a secondary cardiac involvement, such as sepsis, inflammation, Takotsubo, stress cardiomyopathy. These patients generally have low-level troponins, a markedly abnormal pulmonary pathology, and the treatment is pretty much respiratory care and COVID management. Then you have patients who may have some underlying cardiac disease or a combined pulmonary cardiac insult because of the nature of the viral infectivity or damage to the heart and endothelial cells as well as the lungs. They typically have low output and they still have minimal troponins, but they have global LV dysfunction, and the treatment is pretty supportive, as you can see here, and possibly mechanical support. And then what we're talking about here on the right is what's more confusing. So these are patients who the STEMI or the non-STEMI insult is out of proportion to the lung decompensation. These patients have high troponins, perhaps regional wall motion abnormalities on their echo, and you have to decide whether to go for primary PCI or lytics or how to investigate that and rule those out or rule those in, treat them or not treat them, and then whatever's left is by definition a myocarditis or some kind of spasm or something else that can be treated with the cocktail you see in that last box. But that's where it gets confusing. So when we took all these things into consideration, we came up with these recommendations, and they seem fairly in tune with the ACC and expanded upon them. First and foremost, all STEMI patients should be rapidly screened for COVID in the emergency room, and that can be rapid with history and clinical symptoms in their presentation. Given the low current prevalence of COVID in the general community and that system resources are not currently strained, primary PCI should remain the primary strategy, both for COVID and non-COVID patients, with patients getting, staff getting full PPE, a mask on the patient, negative pressure room, if possible, terminal cleans to the room, and try to intubate these patients to create a closed circuit if the patient is short of breath or hypoxic or signs of worsening shock, such as SCAI shock stage C through E. Lytics, we said, can be considered for PUI in COVID patients with severe bilateral pneumonia or lower risk STEMI patients. But there are some considerations here. So what is the bleeding risk and effect on prognosis if you already have severe COVID and bilateral pneumonia? Is there a benefit there at all? And what is the benefit in low risk STEMI patients versus simply conservative management? And then finally, as prevalence of COVID increases and system delays manifest, we had to open a door there for a potential time in the future. And we've seen this in Italy and other countries where lytic therapy may have to be considered in a larger portion of patients. But I'll end with a couple of questions just so we can stimulate some discussion here. There's some unanswered questions and concerns when we talk about lytics and door-to-balloon times and primary PCI. So number one, can we reliably and realistically live up to door-to-balloon times and metrics less than 90 minutes during a pandemic? We've never been tested in that situation. 90% of our patients around the country are getting primary PCI, but can we uphold that? So there are, of course, going to be system delays for patient arrival, just by dealing with patients and our overwhelming of the system, space in the ER, screening of all patients, cath lab preparedness upstairs, and these things can easily increase door-to-balloon time by over an hour, even for the non-COVID patient. In this context, is there data that lytics and delayed PCI, slightly delayed, are as good? And there is one trial, and we can talk about that, called the STREAM trial that looked at lytics, door-to-lytic time, versus patients who go to primary PCI if the delay is more than an hour in the system. And we can talk about that. They found really no difference in mortality and obviously slightly higher risk of intracranial hemorrhage in the 30% emergent PCI over the next 1 to 2 days. This whole second question is about healthcare workers, and we've never been used to thinking about ourselves as a valuable resource, as something to concern ourselves with. We've been very conditioned really to think only about the patient and not about our resources in our community. But should we be risking healthcare workers' health and exposure when mortality benefit in this population may not be as clear? There's certainly no randomized trials in patients who are COVID positive. And 10% of affected individuals that we know from Italy or Spain are healthcare workers, which would limit our ability to perform vital services, not just in coronary work, but structural, peripheral, everything else over the course of the pandemic if we started losing people over the course of that duration. And finally, there are some benefits, but also significant real harms to lytic therapy. Obviously, one of the benefits, it allows time to better understand the clinical picture over the next 1 to 2 days, the extent of organ involvement in the COVID patient, overall prognosis. Number two, you can have delayed emergent PCI seen in 1/3 of patients in STREAM can still be performed as a pharmacoinvasive strategy with no increase in mortality, at least by that one trial STREAM, with about 5% mortality in both arms. On the other hand, there's a 1% risk of intracranial hemorrhage anytime you give lytics, and the risk of pulmonary and other hemorrhage in these patients is high, given instrumentation and access site throughout the body. And finally, some of these patients may get lytic therapy for myocarditis or spasm or Takotsubo, increasing bleeding risk without any benefit. And this may be as high as 20 to 30% of ST elevation EKGs in the COVID population. So I'm interested in hearing what my colleagues say, and hopefully we'll get back to brighter sunny days.
Thank you. Yeah, thanks very much, Hari. That's an excellent overview. And I think that opens up a lot of questions which are already coming through the line. But just to kick it off, and then I'll pass it over to Mehdi and to Subhash. Right now, if someone walks into Westchester, is the ER going to call you for primary?
Yes. So,
or will you?
I think you're breaking up for a second there. Did you ask if at Westchester, if they come in with a STEMI, will they be calling us?
Correct. Yeah. If it comes
Yes.
to Westchester, what do you do?
Yes. So right now, we have the capability and running on pretty much as routine. So our ER definitely is feeling the burden of this. But if a patient comes in with STEMI right now, they'll call us for primary PCI, and currently we have the resources to handle that. So patients are coming right up to the cath lab. Our cath lab is prepared. We have one room prepared for this with HEPA filters in that room. We were not able to change our rooms to a negative pressure ventilation, so we have HEPA filters in that room, which is, I guess, the next best alternative. All of our staff have full PPE and have been trained in the donning and doffing of full PPE. And so currently we're treating all STEMIs, whether they're high suspicion or low suspicion, as potentially COVID positive. And we're also tracking those patients through the cath lab to see who turns COVID positive through the next 1 to 2 weeks. So right now we're sticking to a tight door to balloon time, and we're not deviating from that. However, I'm looking to see, as we get more experience, if we find there's more and more patients that come out with normal coronaries. Now that's probably okay when you go to the cath lab and you figured that out and you move them over to the intensive care unit. At least you also have hemodynamics and you have the options of mechanical support if necessary in those populations. But it might come a time that if these patients are really sick and you're not quite sure, and maybe they're young and you think the likelihood of a true ST elevation is low, is there something else you do in the ER that might delay door to balloon time but give you valuable information like an echo or a CAT scan? But we haven't gotten to that point right now. Right now, we are pulling them all to the cath lab as per routine.
Srihari, great presentation. And there is a lot of questions in regards to various screening methods. Are you using any screening methods like echo, various other things to try to supplement to see, because many of these patients are coming with myocarditis or other things. Are you doing anything in addition to what you had been doing before?
Yeah, I think obviously historically when these patients come in, certainly if we were already at home just before the COVID pandemic, we were doing echoes anyway. Our fellows come in and they're doing echoes, they're already in-house and they're doing echoes very quickly. I think this is a population that since we have echoes in the ER, at least at our hospital, we can have a quick look echo for regional wall motion abnormality as the patient's coming up. And that has not been an issue in terms of prolonging door to balloon time. I think personally, we don't have it as a routine, but personally, I would say that I would get echoes a quick look echo on these patients who are known COVID positive. Yes.
Sri, I have a very interesting question on the chat forum. This is Subhash. You know, as we are going to see COVID screenings in the ER, and it'll delay some kind of action from the Cath lab and from the interventional group, and you highlight that. And there might be in the midst of those patients who are very, very low risk. Do you think the questionnaire in the chat forum asks an interesting question? Is there a way for ER, EMS screening for those patients? So as we are screening those who are higher risk for COVID, those that are at a lower risk don't also get delayed and get, you know, additional therapy. So do you foresee that? And the second question is, this is for you and for other panelists as they move through the presentation, are you seeing an extra number of patients that you're getting called upon that are STEMI mimickers or ACS mimickers? Great presentation, Sri. Enjoyed it very much.
Thank you, Subhash. You know, so I think the first question is about screening. I mean, the rapid screening in the ER is, I think, is very important, but, you know, the screening is pretty much a history, fevers, dyspnea, travel, which obviously is becoming less and less important. In terms of bringing patients straight to the lab, we've had a long history, and I'm curious to hear other people say, of bringing patients right to the lab. In terms of our transfers, we quickly instituted a policy of having the transfer center screen these patients through the other hospital and en route. So we do have communication with everybody as the patient's coming in and can do a screen en route, and that'll help us triage the patients that could potentially go straight to the lab versus having to stop in the ER. It is important. We want to make sure that we're not inadvertently causing harm to patients who simply have an ACS that could be treated. There is data, as you all know, that during the pandemic in other countries, there's been an increase in mortality from non-COVID related illness. And it's possibly because of the taxing on the system. And it'll be interesting to see how much of that is cardiac disease that was delayed versus non-cardiac disease going forward.
Yeah, thank you, Hari. I think maybe it's a good time to switch now to Italy, to Mauro Carlino, because actually he may give us a glimpse of what's coming to the US as well when the system becomes overwhelmed, as it's currently in Lombardy. So Mauro, again, thanks for being now. I know it's almost midnight your time, so thank you so much for coming online with us. I know you've learned a lot in the last few weeks and suffered through a lot. So we're eager to hear about your opinions, your thoughts, your experience, and what you recommend for us.
Well, first of all, great presentation, the previous one. I think it focuses very well the situation in this time. And basically, there are a lot of similarities with the Italian situation. I prepared, and can you see my screen?
If you can share, click the share screen in your computer.
I did it.
And then, Terry, you mind just stopping the sharing? Yeah, that's okay. If you can click the bottom again, the bottom green button, share screen. Perfect. Okay. We'll see you now.
Okay. And this is a flow chart we prepared with the German group of Cambis, Masayeki, and basically there are general recommendations for a patient presenting acute coronary syndrome and presumed or clear COVID-19. Well, as before the previous speaker suggested, it's very important to try to screen if the patient is a COVID-19 or high risk of COVID-19 or not. All patients with STEMI are considered to be put in an isolation room, ICU or emergency room, and then he underwent a physical exam, and we evaluate the fever, cough, dyspnea, sepsis, and recent contact with COVID. According to history and clinical symptoms, we decide where we categorize the patient. And in case of doubt, we perform a CT scan. In case of respiratory distress, we avoid aerosolization, avoiding high flow nasal cannula and non-invasive ventilation, ambu bag. And we force intubation eventually in isolated room, avoiding intubation in the Cath lab. If it's possible, in the Cath lab, the airflow should be negative pressure in order to avoid cross contamination. And this is an important point for the cleaning team, we suggest to wait an hour before cleaning, and the people performing this cleaning should wear full PPI after COVID positive.
Can I ask you one quick question, Mark? If you go back on the previous one, how does the CT scan help? So let's say he comes in and there's a question, how is the CT scan helpful?
Could be useful in very limited cases when there is no clear evaluation of the pulmonary situation, and in very selected cases we consider to perform CT scan.
So Mauro, is it a CT to look at the pulmonary vasculature for the infiltrates, the ground glass infiltrates, or is it also to look at the coronaries and get a first glimpse of it?
We consider CT scan for a non-STEMI patient in this case, but we'll see in a short time. Well, I don't know why there is this. Okay. In case of a patient with STEMI, we differentiate from patient from outside and STEMI in-house. In Milan, we created 2 different hubs where patients with coronary acute syndrome are referred. And one of these hospitals is my hospital, which is the San Raffaele Hospital. So if patient coming with STEMI come from outside, we evaluate if are intubated or they undergo cardiopulmonary resuscitation. In this case, we consider as a high probability COVID-19 positive, and in this case we consider to treat in a dedicated Cath lab, and the staff should use personal protective equipment such as FFP2 or 3, goggles and shields, while the patient should use a face mask. In case there is a low probability of positivity to COVID-19, we consider to treat the patient with PCI in the Cath lab with basic protection and face mask. If the patient comes from our hospital, there are much more opportunity to categorize the patient as COVID positive or not. If do they have spontaneous breathing, inadequate oxygenation, non-invasive ventilation? If no, they consider as a patient COVID. They perform or underwent a PCI in COVID Cath lab. If yes, before to perform PCI, we consider an intubation strategy. In patients with severe RDS and ventilated, we consider an individual decision making, and we consider PCI, thrombolysis, or conservative according to stratification of the risk of the patient. Is the patient an old age patient? Which are the comorbidity? And we try to stratify a prognosis. And if we consider as a bad prognosis for short and long term, we consider a conservative treatment. Here the patient presenting with non-STEMI, we prefer to be conservative in this case. We consider to isolate in ICU this patient and to evaluate as before, according to symptom, fever, cough, sepsis. If these are present, and so they have an high probability of COVID infection, we evaluate PCR. If PCR is negative, we can consider to perform a CT scan in order to evaluate a pneumonia. If pneumonia is present, we treat this patient conservatively. in order to get a stabilization of the patient. And in a secondary, later we consider elective diagnostic. If we do not obtain a stabilization of the patient, we consider to treating COVID cath lab this patient as previously described. In a patient with COVID-19, low probability of COVID-19, we evaluate a PCR. If we are negative, we evaluate patient in 24 hours. And if there is not an evolution or a diagnosis of COVID-19, we consider a conventional treatment. If not, if a patient are positive, we consider a conservative treatment, and then we go according to this flow chart.
So Mauro, excellent points. Quick question for you. Let's say the patient is low probability, comes to the cath lab.
Well,
then you do it without the N25, and then he's shown to be positive. So now the whole cath team is exposed to someone who hasn't been without the full PPE. What do you do then? Take the cath team out, or is it worth having full PPE for everyone, the N95 masks, or what are your thoughts on this? Because Italy now, everyone is potentially infected, right? There's so many people.
Yes, we consider the patient, in the majority of cases, we consider a patient as a high probability COVID positive patient. And so we apart very few patients with no likelihood of COVID-19 positivity, we consider to treat with the staff, with the personal protective equipment such as FFP2 or 3, goggles and shield and so on. So according to the fact that the incidence of this disease in Italy is very high, in the majority of cases, we consider patient as a positive.
Okay, perfect.
So Manos, that's what we've done here too. All of our STEMIs coming through, everybody's getting, we all wear N95, not just the procedural mask, because you really can't tell which of these patients, we don't know what the true prevalence is in society. And certainly some communities have higher than not. And this is about reducing the exposure so that your team is available. So we've adopted that mechanism. Where it becomes a challenge is if you have multiple patients in a row and you have to use multiple rooms. You have to make sure you have that availability of those rooms and the availability to clean those rooms properly to use them for non-COVID patients as well.
Sure. How about you, Raj and Sandeep? What do you guys do?
Yeah, I think the point about the prevalence is very important. If the prevalence is low, then following, I think what's been described is pretty good. Where we are now, the prevalence is very high per capita for the number of people we have in the density of our city. So we're working under the assumption that everyone is potentially contagious, everyone is or infectious, and we have to do that. In fact, we've been trying to learn from the Italian example, but we haven't been paying enough attention. So one of my partners, Steve Ramey, has been talking to Alberto Creminosi over there, and we're trying to stay ahead of this, but we're falling behind. So I'll show you some of the changes in the prevalence in a few minutes in the New Orleans area, and how we've adapted to that.
How about you guys, Sandeep, in Chicago?
Yeah, I mean, I agree with that. I think anyone coming from the ER is at least a PUI. And I think in the context of STEMI, it's so hard to get credible data. I'll show you a case in my presentation where we got literally maybe 5 minutes or 3 minutes worth of data before things, the wheels sort of fell off. And so I think everyone has to be considered right out of the gates. I think the balance, though, is that we're really starting to see the upsurge, not quite as much as Raj or perhaps Hari, you guys in New York, but it's certainly getting there. I would say that at this point, at least a fifth to a quarter of our hospital is COVID or COVID PUI. I think the projection is that many of the academic medical centers in the city of Chicago, there's probably about 6 or 7 big ones, are going to be overwhelmed very soon. And our PPE, I think, is in short supply. Very recently, we got a sort of an influx of supply of N95, but up until that point, we were very much conserving as much as possible, trying to be parsimonious. In STEMI, I think all bets are off, though.
Hey, Manos, can I ask you a question? Quick question is that,
Sure.
so the challenge, honestly, I was just on a phone call earlier. That's why I got up, is that, we have our first COVID positive patient that needs to go to the Cath lab. And we just found out that none of our labs are, at least in this hospital, are negative pressure. Hari, you mentioned something. Can you get a kind of a consensus from the group that what you guys have done? I didn't hear you very well when you mentioned.
So there's no good, well, I don't know. The problem is that there is some controversy about negative pressure versus positive pressure. Obviously, negative pressure is better in terms of exposure outside the room. Positive pressure is better, obviously, in terms of sterility. So there's still some controversy about what's more important in that situation. You can use HEPA filters to try to clean the air in the room so that whatever goes out in a positive pressure situation is less contaminated and less exposure, but it's not perfect. We were not able to change to a negative pressure room. Other places, I think, have been able to do that, but I'm actually not sure. How about Sandeep or Raj?
We were able to convert one of our rooms to a negative pressure room. I got to tell you, it took a lot of elbow grease, a lot of convincing, and so now that's a shared resource at our place with interventional radiology, and so that's kind of how we got it done and pushed through relatively quickly. The first couple of cases at the start of this at the beginning of the month, late February, the first cases that were coming in as PUIs, I mean, we just, the case that I'm going to present was done in a non-negative pressure room, and we just had to basically take it out of commission until we fully understood how to do a deep clean and ensure everyone's safety.
How about you guys, Raj?
Just for the audience on the call, in case that people are not sure about the difference between positive pressure and negative pressure. So most ORs are positive pressure rooms. They're rooms where air is pushed into the room to stop contaminants from coming in from outside, whereas negative pressure rooms are more likely what you find in the medical ICU, where air is being sucked out of the room to prevent it from leaving the room and contaminating elsewhere. And so most cath labs are not set up for negative pressure. Right now, we don't have any of our cath labs set up for negative pressure.
Mauro, this is Subhash. Just a quick question from your experience, because the Italian experience is very enlightening and quite exciting to us because we can learn a lot. In addition to having dedicated COVID rooms, do you also have your cath lab schedule oriented in a way that minimizes people taking STEMI calls in certain ways, or they're grouped in a specific way that the schedule work, or it is a regular cath lab schedule, or you have made some changes that are worth learning from?
I can understand, sorry, can you repeat it?
I'm saying that you have indicated that you have COVID high risk, high probability specific cath lab rooms where you perform those procedures. Are you also indicating that there is a single team that takes maybe STEMI calls on a particular day and it is rotated down so that...
Sorry, the interconnection is not good.
But let me repeat, I'm sorry, I think the connection is a little...
Yeah, your connection is not good.
Do you have like specific teams who are taking calls several days so you don't contaminate or expose everyone? But like, do you have some people who take call, let's say, for a week and then take off? So you don't have a separate person every day, separate team with a chance of getting multiple people getting infected within the course of a week?
No, we don't have.
So every day is a separate person, a different person every day. Okay.
Yeah.
Yeah, so we addressed that in the SCAI document, that is one proposed model, so that you expose just a limited amount of staff, and the rest of the staff are not exposed, and their risk is lower. Again, the prevalence of the disease plays into this because you're assuming it's just that patient, but they're going to be seeing all kinds of patients during that time. So we have not gone that way.
And this is a really important issue because in the United States, unlike many other countries, there is no pooling of STEMI services. So many smaller hospitals have STEMI services. And it is critical that those services are maintained, because then the SCAI document actually does a great job addressing this issue. And thank you, Sri, for leading that effort.
Yeah. Could I add, so because our prevalence is very high per capita here, we're working under the assumption that one or more of the interventionalists here are going to get infected. Hopefully we won't, but we're planning on plan for the worst, right? So we're taking call a week at a time. Those over 60 are not taking call in the cath lab cycle. So we do night call for a week. The following week, we do daytime urgent emergent cases. And then the following week, we're in the ICU rotation. And then we take a quarantine week after spending a week in the ICU. And that way we have some redundancy in our cath lab call system in case someone goes down.
Rajan, thank you for sharing that. I just want to say that, this is because we are, a lot of our cities are not where you are. And I think a lot of the people that are, there's over 300 folks right now participating in this webinar. I think these are the most valuable things we can learn, to be honest with you, is that, how do we prepare to get there? I love your suggestion about not having people over the age of 60 take call. This is something that I probably take to our team. I love that. Congratulations.
Yeah, I would echo what Raj said. About a couple of weeks ago, when we kind of got our heads together on this, we decided that that we would take call a week at a time, more or less. If somebody had a particularly bad day, then there would be a second line and a third line to cover the evening. The cardiac ICU, the CCU side of things here are run primarily by interventionalists, so it makes it easy to staff the unit and cover the entire week of cath lab call as well. And then we have people rotate in for evening coverage, maybe a couple of nights a week. But when we're on, it's primarily one person, and we try to limit the number of people that need to be in the room for non-emergent procedures, simply because as the point was made, community transmission and asymptomatic transmission is a big component of this.
Okay, coming back to the question of the webcast. So Mauro, I know you guys have been very stressed out. Have you given thrombolytics yet for STEMI, or you've done still primary PCI for all your cases?
We consider basically primary PCI for all patients because due to the risk of performing thrombolysis in patient with high risk of hemorrhage or a patient with Takasubo or myocarditis or other pictures such as this, we prefer to consider to treat in a better way the patient when we consider to be treated, and so we don't use thrombolytics.
Manas, I know you want to move on. I want to ask a very interesting question from the chat. Mauro, do you guys use, or any one of you in the panel use, that automatic CPR machine in this situation? Have you guys used that? Because I think that would be quite interesting.
We do, Subhash, and that not to steal my own thunder here, but the case is going to be using Lucas.
If you don't have one, now's the time to get one, right, before you get that case, but absolutely. Yeah, thank you so much, Mauro. I mean, is there another slide you want to present to us, or should we move on to Raj?
The last slide I want to show you is about a paper published in JAMA showing mortality during the hospitalization between patient with versus without cardiac injury. And you can see how different are the curve in patient without cardiac injury and with cardiac injury. This is a very important point in my opinion.
Yeah, thanks very much, Mauro. And I guess what you're saying is an argument for both lytics and PCI. For example, if it's a non-coronary and you do the cath, you're done. You don't get the risk of lytics. So it can work both ways. The fact that you have less severe coronary disease, maybe the cath is important because you avoid the risk of the patient to lytics. But again, excellent presentation. Thanks again. We're all with you during these difficult hours, and thanks for sharing all these lessons. And then we'll go on to Dr. Raj Patel, again from Mosner Clinic in New Orleans, who I know it's heating up. So thanks very much, Raj, and looking forward to your thoughts.
All right. Well, thanks, Manas and Subhash, for the opportunity to present with this group. And I'll try and share what we've learned in New Orleans over the last 3 weeks. Hopefully, you guys will learn from what we did or didn't do. So on March 15th, this was the prevalence of COVID-19 patients in the state of Louisiana. Put an arrow on here, maybe can see better. And so on March 29th, a couple days ago, this was the prevalence. So we had 3,500 cases, 151 deaths. The next day, we were up to 4,000 cases, 185 deaths. And as of this morning, at Ashton Medical Center where I work, we had 262 inpatients who were COVID positive. We had 103 on ventilators in the ICU and 68 being ruled out. And that's about the daily average for the last week or so in terms of rule outs. And so just over 2 weeks ago, we realized we were in trouble in more ways than one. And on the Cath lab, from the Cath lab side, this is what we decided to do with our STEMIs based on what had been published from China, South Korea, and Italy. And so for patients who are presenting with STEMI based on clinical and EKG criteria, who are either inpatients, who were known COVID positive patients, or ED patients who are symptomatic, meaning they have a fever, a cough, or the respiratory symptoms, we do a TTE in the ER to confirm a wall motion abnormality that fits with EKG. And if that's the case, we give those patients lytics. But that also gives the Cath lab time to prepare in terms of putting on PPE and getting ready for the patient if there is failure of lytics to do rescue PCI. If the patient does not meet those criteria, then we go for primary PCI. Now that's changed over the last week. Now we're working under the assumption that everyone is presumably infectious, whereas 2 weeks ago we weren't. And so just to review STEMI management with lytics, everyone gets an aspirin, everyone gets Plavix loaded. If they're over 75, then they only get 75 milligrams. They get put on they get a heparin drip in bolus and statin. And then this is the management if you give TPA. So our hospital, as it turns out, does not have TNK, and we cannot get TNK. We're working on getting it. But because we do a lot of peripherals, we have lots of TPA around. So this is how you give TPA in case you don't remember from when you were a resident or longer. So it's for most patients in Louisiana, most of our patients are over 67 kilograms. It's a 15 milligram IV bolus, then you get a 50 milligram infusion, then a 35 milligram infusion. Total dose is 100 milligrams. If you're less than 67 kilograms, then you dose adjust, as shown here. And then before giving lytics, of course, you have to go through a checklist. This is the same checklist you go through before giving lytics for an acute stroke. So any history of intracranial hemorrhage and you're out. If you've had a stroke over 3 months ago, or less than 3 months ago, or over 3 hours ago, I should say stroke, not intracranial hemorrhage. Any cerebrovascular malformation, intracranial malignancy, aortic dissection, active bleeding, diathesis, or closed head facial trauma within the last 3 months. Now for NSTEMIs, everyone's getting obviously guideline-directed medical therapy, but if they're stable, then we just continue medical therapy. We're not cathing these patients at present just because of the exposure risk. If they're hemodynamically unstable or having ongoing evidence of myocardial ischemia, then we'll take those patients to the Cath lab. So this is what we've been doing to minimize exposure of that patient to the rest of the hospital, as well as to our Cath lab staff, and try and prevent potentially unneeded spread of the infection. And the reason that we're doing this way now is because, again, the high prevalence in our community. For asymptomatic patients coming to our emergency department with NSTEMIs, they're presumed infectious until proven otherwise, as I said. All our Cath lab staff are required to wear our institutional PPE standard for COVID-19. Post-procedure, they go into an isolation room until proven negative. And then, of course, after each Cath lab finishes with that patient, there's a terminal clean of that patient. And the last thing the Cath lab gets is a treatment with a UV light robot. So that's where we are in terms of treating STEMIs and other ACS patients in New Orleans.
Yeah, thanks, Raj. So one question that came in. First of all, who does the echo? You said the echo is done if a patient comes with suspected STEMI. So that assumes, I mean, you do have trainees or some staff are in-house to do that. Who does the emergency echo?
Right, so we have a fairly large cardiology fellowship program. We're fortunate for that. We have 30 cardiology fellows. So we always have a cardiology fellow in the ER in the daytime, and then one being paid to moonlight in the evenings. So that's who's doing the.
That seems like an excellent strategy. You may rule out a lot of people who actually are false STEMIs, and you might avoid a lot of activations and even save them lytics if the wall motion is normal. So it's an excellent idea.
Yeah, that's the major concern, as others have pointed out. We don't want to give lytics to someone who's not actually having a STEMI.
Are they also helping, Raj? That's wonderful presentation, by the way, you know, amazing work. But are they also helping with the non-STEMIs? Because I think that I love how you're triaging the non-STEMIs, I think, because people have this assumption, non-STEMI cath lab. Yeah. Even honestly, right now, you know, we came up with essential, non-essential. We put non-STEMI under essential. Right now in my own hospital, and I'm in charge of the cath lab, we have selected non-STEMI as essential. I think we need to be open-minded that even non-STEMI, there is non-STEMI and there is non-STEMI. Do you agree with that? Are you doing that in the ED? The fellow does that? Who does that?
Yeah, our cardiology fellows have been extremely helpful in helping us manage these patients. We couldn't do it without them, in fact. They've been great. And as you said, they're NSTEMIs who can be basically treated adequately with guideline-directed medical therapy, who don't have recurrent ischemia. And so those patients we're putting on medical therapy and discharging with a telehealth follow-up. For those who have evidence of ongoing ischemia, we're taking them to the cath lab and treat them as we normally do.
Rajan, superb presentation, right to the point. This is Subhash. 3 questions. Number 1, in a non-STEMI situation, if the COVID test that routinely takes 2 to 3 days in a hospital setting, I'm sure that's the same as yours, it comes back negative. Do you then change your strategy for those patients and go back to the usual? That's question number 1. And second, what can you say from your experience? What should smaller hospitals do that do not have fellows? If you didn't have the fellows, would you deem the echo still as important? And so that the attending interventionalist or someone else who is helping the attending interventionalist can actually do the echo if you do feel that it is that critical. So 2 questions, please.
Right, so the first question, what do we do with the NSTEMI patients who we put on medical therapy while we're waiting for the COVID test to come back? So as you said, until yesterday, we did not have a quick turnaround on our COVID test. We now do, actually. It's being done in-house, so we have a quick turnaround. But until yesterday, an NSTEMI patient would be discharged home on medical therapy with a telehealth follow-up. And then if they were having symptoms at home, then we'd bring them back for, potentially a cath. They'll probably change now that we have a rapid turnaround. But issues that remain to be discussed with our group regarding that are, what is the sensitivity of that rapid COVID test?
And rapid is 1 day or a few hours?
I think within 24 hours.
Yeah, I think the rest of the population in the country is going to benefit from the fact that turnaround times have improved. It went from a week to about 2 to 3 days, and then now is same day. And obviously with new testing will be even more rapid. So I think in the future, depending on how that rolls out from other companies and whatnot, and the big step was doing it in-house, you can potentially do the NSTEMI later in the same day if necessary and go about your business. Obviously there's a sensitivity specificity issue there that has to evolve, but I think that's probably where ACC in their first statement mentioned to keep the non-STEMI until the testing is positive or negative and then proceed based on that testing.
Subhash, I have a slide on the chronology of tests. Actually, the director of our microbiology and pathology lab has been sort of on the cutting edge of this, at least in the state of Illinois. So we've had access to some of those tests in-house for a little while now.
I think you all are making fantastic points. I think these strategies that interlace the hospital testing feasibilities and the cath lab strategies, the interface of those two are going to be critical for those who are listening to your webcast and presentation. So thank you for clearly elucidating that points.
Subhash, I also think that maybe this is the time for smaller hospitals to teach the ER how to do at least a parasternal and a quick looks. I don't think that that's unreasonable if you have a week to teach a few people. Ultrasound is very common in ER residencies and training as it is. And so they may be able to do at least a basic 1 or 2 views to give you some idea of what's going on.
Just to add some spice to this discussion, we do not have an ER physician here, but I think there is a lot on the chat lines. I think we have to take their side too, that they can be actually pretty overwhelmed with what is going on. And if you imagine a New Orleans ER, I think that is we all agree that the echo, and Manas made that point, that the echo is a very good screening tool. And I think putting that effort into that echo, whether it is ER or cardiology, I think would save a lot of unnecessary invasive procedures. That point is, I think, is clearly well taken.
Just one quick question, Rajan, then we'll move on to Sandeep. But the question here is, do you see less STEMIs these days after the COVID epidemic, or are you still seeing the full spectrum, the full numbers as before?
Yeah, great question. Our STEMI volume has decreased exponentially over the last 3 weeks. So I was on call last week, and we only got 2 STEMIs the whole week.
Okay, so I guess the saving grace here is maybe it's a little elaborate, but many people are not coming, or the less severe cases don't come, so maybe the number of cases will be less, which helps obviously with everything else.
Yeah, I'm not sure I understand what's happening there.
Sure.
Yeah, we're seeing that in the York area as well. Definitely a lot less STEMIs than, and they showed this in Italy as well in terms of the 2-week period of STEMI incidents. I can't imagine they're actually not happening. I think they're not being seen, and when the dust settles, we may see an increased death rate from that. I'm concerned about it.
Yeah, thank you so much. And then last but not least, again, Dr. Sandeep from University of Chicago. He has a personal experience actually with STEMI and COVID possible patients. So looking forward to hearing your thoughts.
Okay, Manos, Subhash, thank you so much to the group for inviting me. Can everyone see my screen okay?
Yep.
Okay, great. So, I'm going to amplify some of the points that have already been made by the other speakers and just add a little bit more data to this. So I think we all know at this point where this began. It's sort of interesting, not to get mired in the history of medicine, but if you look at the differing accounts from the start of this, it's really pretty fascinating how this happened. I think we all know that this is a zoonotic virus that is likely transmitted from bats to humans through an intermediary, which, as it turns out, appears to be the pangolin. One little nugget that's sort of buried in the early data is that there's probably already 2 subtypes of this virus, and that subtype has already shifted as the experience has moved away from Wuhan to the rest of the world. It's unclear what the difference between the L-type and the S-type viruses in terms of its virulence and its impact on outcomes. This is the heat map and dashboard from Hopkins. As recently as a couple of hours ago, you could see that the world has sort of exploded. But all the while, to amplify the point that Raj made, there hasn't been a lot of noise about ST segment elevation, myocardial infarction, although certainly it's happening. It's not coming to the fore as we sort of expected that it might. Certainly if I refresh the screen now, I suspect that it's probably over 850,000 cases worldwide. So we know what the basic pathobiology is, and I think for us as cardiologists, as cardiovascular specialists, the concern is that the ACE2 receptor, which is abundantly expressed in alveolar cells and the main mechanism of entry into the lungs, is also abundantly expressed in the heart. And many of our patients have cardiovascular disease. What we know about patients with CV disease who contract COVID-19 is that the case fatality rate appears to be at least 4 times the case fatality rate that was reported in the Chinese experience of about 2.5%. About 7% of COVID-19 patients suffered detectable myonecrosis, about 22% in the critically ill cohort, and perhaps more than that. So that just sort of muddies the water further in terms of how we look at these patients. These are some very important, small scale, but very important data from China that was published in JAMA Cardiology. As you can see here, if you sort of stratify patients based on a history of cardiovascular disease and troponin elevation, yes, no, what you see is the stair-step elevation that culminates with a mortality of almost 70% in patients who have got a history of cardiovascular disease and persistently elevated troponin T. This is a far cry from the 2.3% that's reported so far in China, in Hubei province, and 4.5 to 5% that's reported so far the world over. Some guidance from this clinical document from the American College of Cardiology, which more or less frames some of the points that I made. Cardiovascular disease patients with COVID have a case fatality rate of about 10.5%. With cardiac complications that are sort of commensurate with other coronavirus-based diseases, as well as influenza. I think the fly in the ointment for this discussion of lytics versus primary PCI is this paper, really a letter from some colleagues in China that suggested a fibrinolytic forward approach, if you will, for the majority of patients, and really picking over the patients that are going to go to the cath lab for ST elevation myocardial infarction. The response from FSCAI and from ACC's Interventional Council was worded thusly, that in confirmed COVID-19 patients, in the presence of a STEMI or non-STEMI with ongoing hemodynamic compromise, these patients should be taken to the cath lab. And certainly for PUIs, and everybody's a PUI these days, unfortunately, in urban centers, we certainly don't have the numbers of New York or what, Raj, you're seeing in New Orleans. But right now, about a quarter of our hospital at the University of Chicago is COVID positive or COVID rule out patients. So it's a pretty substantial number of patients. Even over the past week, we've seen not quite an exponential growth, but more than a linear growth in these patients. And so this is becoming an increasingly common issue. Possible COVID-19 patients with STEMI treated as we would normally with all the appropriate infectious protection. Everyone is a potential PUI. These are sort of the practical considerations, but you got to ask yourself, how likely is the patient to be actively infected and spreading droplets? How urgent at the end of the day are the invasive diagnostics and therapeutics? Is this secondary myocardial injury related to the COVID infection, or is this truly a de novo ACS STEMI? And obviously that's a very nuanced question. And if COVID positivity and droplet risks are both high, what's the likelihood that they're going to require innovation to perform the case? And would this lead to a clinically relevant delay? I would submit that in somebody who's very likely to decompensate in the lab, I think everyone is better off if that patient is intubated and this becomes a closed circuit before you end up in the cath lab with a patient that you're trying to manage on a non-rebreather or worse, an ambu bag and spraying droplets all over the place. And finally, could this be stress cardiomyopathy or myocarditis mimicking STEMI? There's been lots of reports now popping up both on social media and other outlets on myocarditis, both localizing by ECG as well as wall motion abnormalities associated with normal coronaries. So here's a patient, and spoiler alert, there's nothing good about this case. 60-year-old female with only past medical history of smoking in the past and hypertension, brought in by CFD with a 1-week history of dyspnea. This is what she led with. She led with dyspnea, non-productive cough, malaise, possible subjective fever, flu-like symptoms, and prominent body aches. Increasing chest discomfort for a day or more is what actually brought her in. The ED staff got about 3 or 5 minutes into the conversation, at which point she arrested in front of them, had a VF arrest. ROSC was briefly achieved after 6 shocks and 5 rounds of CPR, but again, she had a PEA arrest. 40 minutes of CPR ensued with intermittent VF and PEA. ROSC was achieved and an ECG and a BBG were obtained. But notably, despite intubation, she had poor oxygenation the entire time. You could see on the ECG that she's got a QS complex in the aneuroseptal leads with some ST segment elevation. It's not classically ischemic, but this is a big difference from the only ECG we had in the system from many years ago, which was a stone cold normal ECG, normal voltages across the anterior wall. And certainly this is sort of a marginal case. I think reasonable people could disagree about what to do with somebody like this who sort of led with lots of other symptoms other than the chest pain, but it's very difficult to ignore this once we actually have this on an ECG. So we did go to the cath lab, and Subhash, those are Lucas chest compressions, providing about 80 to 90 millimeters.
More importantly, Sandeep, that's a femoral cath.
I was afraid you were going to bring this up.
Oh my God, you made a mistake. I'm going to save this for posterity.
I knew you were going to bring that up. I suspected that. Yes, it was a femoral case. We, we wanted to stay about as far away as we could. And there's been some interesting dialogue on Twitter about this, whether it really makes a difference. Anyway, the groins were prepped. She became bradyasystolic soon after she hit the table. She arrived maxed on 3 pressors. You can see that the VBG looks abysmal. The lactate is already 13.5, and the pH is 6.9 when she hits the table. LADs occluded. All lab members gowned appropriately, wearing N95 respirators, full visor, face shields, which, for folks who haven't been through this fire drill, it actually takes a significant amount of time to ensure that everybody is protected. This is not just throwing a hat on, pinning a mask to your face and jumping in there with some gloves. It definitely takes a few extra minutes to ensure everybody's safety, even when we have the luxury of a little bit of lead time to get this done. You can see that there's absolutely nothing going on here, despite 92 millimeters of metal, aspiration, thrombectomy, intracoronary medications, parenteral medications, IV antiplatelets, pulse spray vasodilators, and multiple stents. She remains more or less in asystole and shock-resistant VF. Now, around the same time that we did this case, we did have a conversation in-house with all of the stakeholders, the VAD team, the ECMO team, cardiothoracic surgery, and ourselves in interventional cardiology, what our limits would be for putting somebody on ECMO. And there were, unfortunately, despite her age being relatively young, there were several unfavorable characteristics here even before we got to this unfortunate juncture. We did have ongoing discussions with the POA, which helped establish some stopping limits, and given the extent of the resuscitation and the possibility of a primary respiratory process. And so after an extensive resuscitative effort, we couldn't keep the LAD open. Pretty much everything shut down. At no point did we ever get a perfusing rhythm in this case, and that happened pretty much from the time that she hit the door. The interesting piece of this, I mean, this is an unfortunate case of an unresuscitatable patient that comes in with cardiac arrest or arrest as soon as they get there. The interesting piece of this is, how do you proceed in terms of risk stratifying the exposure? Now, we as providers that were prepared for this were completely gowned and appropriately, covered in PPE, but there's still that lingering concern that perhaps there was some exposure. We were able to obtain a single flocked nasopharyngeal swab that was obtained after intubation, which came back a few hours later as negative. And this is on the Roche Cobas 6800 system. And I'll share with you one slide on the chronology of this. And I guess that gave us some consolation. I'd love to hear what the other panelists are doing at their institutions. We're still doing, for the majority of patients that are high likelihood, PUIs, we're doing two tests that are run a couple of days later to make sure that we actually catch the window in which they're infectious. Unfortunately, given the nature of this scenario, we were only able to get one test. So that's still a bit of an open loop. So I kind of put it to Twitter. I was, bothered for numerous reasons about this. And this is a Twitter poll that I posted over the weekend. And it seems that the majority of the respondents, about 325 respondents, and many of them commented on this as well, are still providing primary PCI for most or all. I put the question, what do we do about STEMI these days? But there were an increasing number of respondents that were using Lytics. Now, Mike Savage from Jefferson put out a similar survey just 1 week before, and these numbers had already shifted in 1 week. Now, I'll fully concede that, Twitter is sort of an inaccurate tool for scientific inquiry, but I think it's the best way to get a bunch of people to respond to you in a hurry. Many of them your colleagues and trusted friends. Ruling out myocarditis is an increasingly relevant concern, although I don't think anybody knows exactly how to do it, because many of these cases will have regional wall motion abnormalities. And I was heartened to see that only about 7% of people responded by saying that they were at crisis level PPE and staffing concerns. Most people still had adequate PPE and staff. So this is what I wanted to share with the group as well, and everybody that's on the line. This is sort of the chronology of rapid molecular point of care COVID-19 testing, which I think will be very relevant to us in the Cath lab. This started with the initial characterization of the genome on January 10th in Shanghai, that resulted 1 week later in the first COVID-19 diagnostic test that was developed by a company in Berlin. Unfortunately, it's a bit of a cumbersome test that uses reverse transcriptase PCR. And when it was operationalized, or something similar was operationalized in the United States, the turnaround time was 48 hours to a week. On March 16th, Roche Diagnostics came out with their first commercial COVID test for automated high volume testing. The turnaround time, and that's what we used here, was 4 to 12 hours. We actually got access to this about a week before it was commercially released in the United States, and we did some of the internal validations for this test. On March 23rd, the US FDA granted approval for the Cepheid expert test. Now, this is, I think, going to be the base of the pyramid for a lot of labs, at least central labs. The turnaround time is 45 minutes. And then most recently on March 27th, we saw the approval of the rapid point of care molecular diagnostic test by Abbott. The turnaround time for a positive test in a patient with a high viral load is about 5 minutes, but if you want a negative test, it's about 13 to 15 minutes, but that's still a far cry from many hours. So now I think that if that's actually got favorable, it demonstrates favorable diagnostic accuracy that's comparable to the automated batch testing. Now I think we have potentially a tool that's relevant for STEMI care in terms of rapidly ruling in or ruling out patients while you're still within a window of making your door to balloon time. So the key takeaway points here, the coexistence of stable CVD and COVID-19 infections portend a particularly poor set of outcomes in China, and there's no reason to believe that that would be any different elsewhere. A sizable proportion of these patients have myonecrosis, which further amplifies case fatality rates. Obviously, there's a balance here between protecting our staff and doing the best we can, providing life-saving therapies for these patients. And for now, primary PCI, I think, remains the preferred approach in otherwise salvageable STEMI patients, meaning they don't have extensive pneumonia or multisystem failure, as well as unstable non-STEMI patients. I think the real wild card here, as in most places, is how long healthcare resources will actually allow for this. We're just bracing for one or more of our interventional team members to get sick and be out of commission for a while, and we're going to be stretched thin without a doubt at some point. And then finally, I shared with you where we are as of today in terms of rapid point of care molecular testing. Maybe that'll help fine-tune this balance a little bit further. Thank you so much.
Wonderful.
Yeah, thank you, Sandeep. That was a phenomenal overview, and you know, I think that was a crazy case that you saw, very challenging. I guess this patient, retrospectively, I mean, probably died from the thrombus, and the COVID was not probably consideration. Although, as you said, the sensitivity of the test is unclear yet, so it's always good to be safe.
Yeah, you know, I mean, one thing that came out in discussions with our immunology folks is that, you know, when the test is validated for nasopharyngeal swabbing, a nasal swab or saliva does not cut it. So everything is based on a very deep, very invasive swab of the nasopharynx. In an intubated patient that's done sort of in haste as this patient is coding and coming to the Cath lab, I'm not sure. I just don't know. And it's a single test. Our protocol has been to test these patients twice to make sure that we catch them when they're in their infectious window.
So Sandeep, this patient is 60 years old, and you know, at transplant centers, oftentimes before the resources are stretched, and I think similar thing would happen here. You know, we know how many ECMO we can do, and we know how many transplants we can do, and VADs and all that. But bed availability becomes an issue, ICU becomes an issue. At that age, oftentimes people would have gone right to ECMO and assumed there's no COVID aspect and there's no resource aspect. You know, I guess I'm not asking you really a question, but for the audience to see that resources get stretched and the decision-making is modified by the pandemic that we're in, and people have to be aware of that.
Yeah, for sure. You know, and as I said, you know, we had a discussion, a very frank discussion with all the stakeholders at the institution shortly before this case. And we'd had, established some stopping parameters of our own. And, we were further informed, the discussion was further informed by the POA of this patient who was very reasonable and, sort of guided us a little bit, and so that sort of shaped the discussion. But I agree. I mean, these are tough decisions to make.
Great. Any other questions? Any other panelists or?
Yes,
a lot of chat questions coming up, and many of them are comments. There were a few questions from the initial presentation, from the first presentation. What is the use, and this is on the chat line, what is the frequency of use? Rajan, this is for you because you've seen probably the maximum number of patients of use of IV steroids. We have a very limited experience in Dallas, and many of these patients are getting IL-6 inhibitions. Some are getting antiretrovirals, special kind that I can't even pronounce. But none of them have actually received IV steroids. Any comment from Sri and from Rajan?
So at our institution, the care of these patients is completely protocoled now. Our pulmonologists and infectious disease team have put together basically an algorithm for what to do when treating these COVID patients on the COVID wards and also in the COVID ICUs. And neither protocol involves steroids because of a report from China suggesting that there are worse outcomes with the use of steroids.
Yes, steroids are controversial. I won't claim to have experience in this, but I think from the prior literature with other viruses over the past 15 years, they certainly didn't help and they seem to have hurt. And so that's part of the issue here. Can they be used? I guess it's going to be a case-by-case basis.
All right. Well, again, I think it was a phenomenal discussion. If I can summarize some of the key take-homes from today's conversation, 6 points. One is that it looks like for most places, at least, primary PCI remains the prevailing way of treating STEMI patients. However, the second point is that lytics are coming one way or another. So brushing up on the protocol and having the ER trained of how to do it, since I've never given lytics myself. So many people are not familiar how to do this. Having a protocol in place will really facilitate things when things happen. The third one is if they come to the Cath lab, they're going to come to the COVID positive room. Fourth, full PPE for the STEMIs. Even if it's unconfirmed, it's suspected, it's good to go. And then for the non-STEMIs, even many people or most people are using now conservative management. And number 6, keep your older interventional partners home. So again, I would like to thank everyone. Just to summarize, Dr. Hari Naidu, Dr. Sandeep Nathan, Dr. Raj Patel, and Dr. Mauro Carlino. Thanks again from all of us from Cardiovascular Innovations, Dr. Subhash Banerjee, Mehdi Shishehbor, and Sorajja. And again, this webcast will be available online for viewing within a few hours. Thank you all very much and stay safe.
Thank you.
Thank you.
Thank you.
Bye-bye.
Thank you.